Good morning. I am Dr. Jahong Kim, Associate Professor of Urology at the UCLA School of Medicine. This morning, we will discuss an important women's health issue regarding vaginal mesh that is used for surgical treatment for female pelvic conditions. At the end of the talk, you will have opportunity to ask questions and join the conversation on Twitter using hashtag UCLAMDChat. Currently, there is overwhelming information about vaginal mesh that has led to misunderstanding and fear. The purpose of this talk is to shed some light on this confusing topic by providing a clear and concise overview of vaginal mesh. So, what are pelvic floor conditions treated with mesh? And what are the standard treatment options for these conditions? How did vaginal mesh evolve? And what is the current FDA warning on vaginal mesh? Well, there are two common pelvic conditions that are treated with mesh. The first is stress urinary incontinence, which is defined as a loss of urine during physical activity due to weaknesses of the pelvic floor. And a woman's lifetime risk of developing this is about 20 to 40%. The second condition is pelvic organ prolapse, which is a vaginal bulge of pelvic organs such as bladder, uterus, or intestines, resulting from weaknesses of the pelvic floor. And a lifetime risk can be anywhere from 30 to 50%. And we know that pelvic floor disease is a global burden affecting millions of women. The prevalence increases with age, and it can significantly impact a woman's quality of life. Some of the known risk factors include vaginal childbirth, obesity, prior surgery such as hysterectomy, trauma, and some chronic medical conditions such as diabetes. We also know that there's an increase in demand for health care related to pelvic conditions. The good news is that women are living longer and having an active lifestyle. The bad news is that at least 11% will have a lifetime risk of needing surgery for either incontinence or prolapse, and 30% of them will need reoperation. So why is management of pelvic floor disease challenging? Well, we know that there are several support defects that coexist. As you can see in this diagram, both the bladder and the uterus can descend to the pelvic floor, along with the rectum, to cause symptoms. And simple anatomic repair does not always restore function. And there are few large randomized control studies comparing the different techniques to guide us to the best treatment. And finally, female pelvic anatomy can be quite complex. So what are the treatment options? The two broad categories are non-surgical and surgical. The non-surgical options include pelvic floor rehab, such as Kegel exercises. Some medications can be helpful for incontinence, and women who do not want surgery can offer pessary insertion. And over the past century, there have been several surgical treatment options and approaches vaginally, abdominally, and robotically. But due to the high reoperation rate, there has been development of mesh augmented repairs to increase the durability and the success rate. So how did mesh evolve? What is mesh? It is a synthetic or biologic net-like material that is used to give strength to the weakened tissues of the pelvic floor. And it has evolved over the past 50 years from surgical mesh that was first used for abdominal hernias to the soft Prolene mesh that is used today. It was first FDA approved for stress urinary incontinence in 1996. And in 2002, the first mesh kit was approved for use of prolapse. Here's a closer look at the different types of mesh that have been used in the past. You can see that there's differences in the pore size, the filament type, and the material type. We now know that one of the most important physical properties is to have a large pore size, as seen down here. The reason is the large pore size allows macrophages, which are important for our immune system to enter the mesh and decrease the chance of infection and allow tissue ingrowth. Here's the soft Prolene mesh, which is used in most mesh kits today. It is 70% more flexible than the other types of mesh and is 66% open to facilitate tissue ingrowth. And since then, there has been an explosion of the different type of mesh kits that are manufactured. The first one that was manufactured and developed was the tension-free vaginal tape, or the TVT. It is used to support the urethra in a retropubic fashion. And since 1996, there have been over 3 million cases used to treat incontinence. And these few slides will illustrate the various different types of mesh kits used for prolapse. They all use different types of trocars and delivery methods. So what is the efficacy of mesh? What are the benefits of mesh? What is the success rate? And how does mesh compare to the native tissue repair? Well, the perceived benefits of mesh are that it is non-carcinogenic, it is non-immunogenic, it's mechanically strong, stronger than our native tissues. It's easily available. It is theoretically resistant to infection, shrinkage. It is supposed to be pliable. And most importantly, it avoids invasive graft harvest, thereby leading to quicker surgery and recovery time. And when we measure the efficacy of vaginal mesh for incontinence, we look at both objective and subjective outcomes. After an extensive literature review, AUA guidelines that was reported in 2009 showed that the success rate of a mesh sling was 88% over a 4-year period, and that patient satisfaction rate was about 89%. Compared to that, when they evaluated the success rate of native tissue sling using autologous fascia, the objective success rate was about 81% over 4 years, with 83% patient satisfaction. So how about the efficacy of vaginal mesh for prolapse repair? Well, after an extensive literature review by the FDA due to the growing number of concerns of complications, they concluded that although a transvaginal mesh repair of prolapse may result in good anatomic restoration, it may not have the benefit compared to traditional non-mesh repair due to the increased risk of complications. It has been suggested that it has longer and better anatomic outcome, but no difference in patient satisfaction or reoperation rate. Furthermore, whether or not you have mesh, the quality of life after surgery may be similar. So how safe is mesh sling for incontinence? Well, the American Urological Association released a statement in October of 2013, and it was soon followed by a joint statement by different organizations stating that the polypropylene mesh mid-urethral sling is the recognized worldwide standard of care for the surgical treatment of stress urinary incontinence. The procedure is considered safe, effective, and has improved the quality of life for millions of women. And this was concluded after evaluating over 3 million procedures that were performed with perceived reports of minor complications. And according to the recent data, the soft Prolene mesh that are used have been proven to be safe, durable, and efficacious up to 17 years. What we don't know, however, is that there are so many underreported complications that we're seeing in tertiary care practices, such as UCLA. So how safe is mesh for prolapse? Well, the FDA released a public health notification stating that complications associated with transvaginal placement of surgical mesh, although rare, can have serious consequences. But due to the growing number of concerns and reports of complications, they reissued a public safety warning on mesh in 2011, stating that complications associated with surgical mesh for transvaginal repair prolapse are not rare. Furthermore, it is not clear that transvaginal prolapse repair with mesh is more effective than traditional non-mesh repair, and it may expose patients to greater risk. So what are some of the complications of vaginal mesh? The most common ones are infections and vaginal extrusion. Some women also suffer from erosion to the urethra and bladder. Others have complained of urinary retention that required chronic and daily catheterizations. Some have complained of sexual dysfunction, very severe to mild, due to the fibrosis and scarring that occur from mesh. Some have required operations for serious bowel injuries. Others have had vascular complications, including bleeding and thromboembolism. And some suffer from chronic pain due to neurologic damages. And others have very bothersome voiding dysfunction, such as urinary frequency and urgency. And some of the rare complications are fistulas, and there have been very few cases of mortality from mesh, and there is growing concern and data about immunologic reactions to mesh. All these complications can be quite life-altering. So what do I recommend my patients? These are some of the common questions I get in my clinic. How do I know if mesh needs to be removed? Is there an alternative to mesh? Who can I talk to about my pelvic conditions? And who should I see for mesh-related problems? My advice to patients is, first, you have to observe for any red flags, such as signs and symptoms. For example, patients may have pain with urination. They may have pain with intercourse, either to self or to their partner. You can have pain in the groin area or the general pelvic area. Sometimes you could have recurrent urinary tract infections of unclear etiology. You can also see blood in the vagina or urine or stool. Some have difficulty urinating or cannot urinate at all. Others complain of frequent urination or severe urinary urgency. Some have numbness or weakness of the lower extremities, and some have unexplained rash, joint stiffness, and fever. All these signs require for you to seek medical attention. So, what is a proper evaluation of mesh complications? I always begin with a complete history and physical exam. This history requires noting what type and when the mesh surgery was used, what type of kit was used especially. And the physical exam is important to look for any vaginal extrusion of mesh, particular areas of pain, and recurrent prolapse or incontinence. Simple urinalysis is very important to rule out any microscopic blood and also occult infections. A bladder scan can be very helpful to rule out urinary retention or incomplete emptying due to obstruction from mesh sling. And cystoscopy is very important to rule out any erosion of mesh in the bladder. Here you can see a photograph of a cystoscopic evaluation of a patient who developed mesh erosion into the bladder. Here at UCLA, we also perform a very special ultrasound called translabial ultrasound. It is the only reliable test that is able to safely detect and localize transvaginal mesh. Sometimes we arrange for MRI and CT scan to look for any pelvic fluid collections and misplacements of mesh. And if you have very bothersome voiding dysfunction, we also obtain urodynamic testing. So how are mesh complications managed? Well, it's very challenging due to the heterogeneity of symptoms. And we try to offer conservative therapy based on symptom severity. However, more often than not, we do recommend removal of mesh, either complete removal or partial removal due to the severity of the symptoms. We counsel patients very carefully about the morbidity associated with mesh removal. Sometimes we need a staged approach to the mesh removal. First, to remove the offending mesh causing all these symptoms, and then the second, to address any recurrent or incontinence of prolapse that occur afterwards. There are many alternative surgical options to mesh repair. For stress incontinence, there is a well-developed technique using autologous fascia harvested from either the rectus or the left thigh area. You can also have bladder neck suspensions, and in some cases, injectable therapy. And for prolapse, there are other native tissue repairs such as anterior colporrhaphy and abdominal and robotic sacrocolpopexy. So who can you talk to about pelvic conditions? I think the first step is to discuss it with a primary care physician who can refer you to a female pelvic medicine and reconstructive surgery specialist in your network. Finally, if you're contemplating having surgery for your pelvic floor conditions, you must do your research. You should ask your surgeon about all the options of treatment, including non-surgical options, as we discussed. You have to also have a clear understanding about the impact on your lifestyle and carefully weigh the risks and benefits of surgery. You should have a very clear knowledge about the post-op recovery and consider the need for future reoperation. So in summary, vaginal mesh that is used for surgical treatment of stress incontinence is considered safe, durable, and efficacious up to 17 years. However, there is a growing number of complications that are underreported and require reoperation or removal. Vaginal mesh used for surgical repair of pelvic organ prolapse may not have benefit over native tissue repair and is currently under investigation. The complications due to vaginal mesh surgery are not rare and can be serious and life-altering. And you must also note that there are several non-mesh surgical alternatives which can offer similar outcomes. Thank you for tuning in, and I will now answer any questions you may have. So the first question I see here is, what if I already have had surgery with mesh to treat stress urinary incontinence? Should I have the mesh removed? I think that is an important question, and as I showed on one of the slides, should I go back? Or if you have any of these symptoms, such as pain with urination, pain with intercourse, infections, blood, difficulty urinating, it's worthwhile talking to your surgeon about it, who can do further testing. The second question is, what other complications are you seeing with mesh? These are some of the complications that are well known, but as I've noted to you, we still don't clearly understand our own body's response to mesh. It is a focus of the research at UCLA, and we're constantly looking at different ways to help patients who have mesh. Third question, can mesh lead to autoimmune disorders? This is a very good question. Again, I think that it is a focus of our research. We are looking at patients who come in with very interesting rash, new joint stiffness, and pain that go away after mesh is removed. So this is something that you need to investigate by seeing your primary care physician and for referral to a specialist. What should women do if they're suffering after having mesh implanted? I think the first step is to talk to your surgeon about it. These complications can occur immediately after mesh. It could happen 5 years, and it could occur 10 years. So it's worthwhile talking to your surgeon who can do the testing as we discussed to find out if mesh was responsible. Do you always go in abdominally for revision surgery? This is certainly not the usual or the first approach. The first thing we try to do is do as minimally invasive procedure to address mesh complications. We usually approach it vaginally to remove any mesh, and we can do concomitant vaginal reconstruction at the same time. However, if the mesh was placed in an abdominal fashion, then we may need to do some exploration through the abdomen. And finally, is pain in the hip, legs, and groin a complication of mesh? That is a potential complication. Sometimes, because of the way the mesh is inserted, it can injure the nerves in the groin area, in the suprapubic area, in the vaginal area, that can lead to chronic pain. If your pain started after mesh surgery, it is definitely worthwhile talking to your surgeon or physician or a specialist in your area. Thank you. I also have some other questions that I usually get asked. Where can I go to find out more about mesh? There is a very good and concise summary that can be found at the FDA website. furthermore, the American Urogynecological Society has a great website with a great file, PDF file on mesh. How do I report mesh-related complications? This is absolutely important because we still don't know the exact complication rate because these are underreported complications. The FDA has a portal that allows voluntary reporting of mesh-related complications. Where can I see a list of mesh devices that have been recalled? Again, the FDA keeps a very up-to-date information of all the surgical devices, not just related to mesh, that have been recalled. How is vaginal mesh removed? This really depends on what type of mesh was placed, how it was placed, and what kind of complications you're having. If it's a simple vaginal extrusion, it can be approached vaginally with an incision and excision. If the mesh has eroded into the bladder, as a photograph we have shown earlier, it may require further and more invasive procedures, sometimes through the abdominal approach. Thank you.